It's there, yeah. It's ready to go. That's fantastic. Thank you, Charlie. Thank you very much, Ruth, for that generous introduction, and thank you, Joe, and to the school for this opportunity to come and speak. I've spoken a couple of times before at the McGill School, and I think it's unique in its ability to get such a wide range of guests on a range of topics in a space in which we have a chance to step back from everyday controversies and to really reflect more deeply. So I'm hoping to try and avail of that opportunity this evening. I'm very much picking up on themes introduced so ably by Ruth, and if I may return the introduction. Ruth is a distinguished author of a history of the Irish healthcare system in the 19th and early 20th century, which has really been the seminal work in the field. So, fit for purpose. Whose purpose are we talking about, and what purpose? And what strikes me when you look at that phrase and apply it to health is that there are many purposes and many players involved in health. There's each of us as an individual. We could be patients, we could be carers, we could be employees or providers. Most fundamentally, I think, though, when we look at the healthcare system as individuals, we ask, in terms of its purpose, will we know we'll get the care we need when we need it? But for society as a whole, the healthcare system plays a purpose. Because beyond ourselves, if we are well, it is still in our interests that others should live long, healthy lives. And in our interests that there should be care for people who can't care for themselves. And going beyond that again, and wearing my economist hat, I would say that there is a purpose to the healthcare system for the economy as a whole. It's important. It's a huge tranche of our spending, public and private. It's very important we spend cost effectively. It's very important we can finance it sustainably, and that we can anticipate and plan for the investment needs of the health service, which is a difficult thing to do. So I'm going to try and look at the issues I discussed this evening through those various lenses and come back to them at different times. And of course, some of those purposes conflict with one another, which is why I think that in any country, the arrangement of the health system and of the health service is a topic of debate. I'm going to pick up the themes introduced by Ruth. I want to talk about the case for universality in health. I want to talk about the case for universal health care in general practice. I want to talk about how we finance universal health care and the case for universality in hospital care. So I think it's very interesting to look outside our island for a moment that the World Health Organization has now adopted universal health coverage, as they call it, but in effect universality, as a major goal. And only 2 weeks ago, the Director General of the WHO, Dr Margaret Chan, directed this statement to world leaders. No one should risk financial ruin because they need health care, and no one should be denied health services because they can't afford to pay for them. The best way to assure meaningful progress towards the new global health goal is for countries to move closer to universal health coverage. And the WHO recommended that the first step should be to reduce the need for people to pay directly for services out of their own pockets at the point of delivery. And of course, this has huge resonance for us in Ireland right now. Just last month, the WHO published this report, and it's its first global monitoring report tracking universal health coverage. It's quite interesting. If you Google universal health care, you'll discover that all over the world there are debates going on about moving to universal health coverage, and in countries that are a lot poorer than this one. The WHO definition of universality in this report is that all people receive the quality, essential health service they need without being exposed to financial hardship, actually with overtones of the poor law wording. But when you read down, that there should be financial protection for all. And the WHO makes the point that universal health care is a social equaliser and a contributor to cohesion and stability. So going beyond the healthcare service to the kind of society that we have. The programme for government of 2011, I think, was quite historic in making this commitment. and was conscious of being historic in making this commitment, as the first in the history of the state committed to developing a universal single-tier health service which guarantees access to medical care based on need, not income, therefore designed according to the European principle of social solidarity, access according to need, payment according to ability to pay. And that is very much, that ambition, that goal, is very much in accord with the direction that WHO is suggesting for governments. So universalism in Ireland, Ruth referenced the education system, and I think many of us who are interested in healthcare reform do look with some bafflement at the acceptance of universalism in healthcare, in education, but not in healthcare in Ireland. We've had universal national school education since the 19th century, secondary school education since the 1960s, third-level education since the 1990s. Now, you might argue, and it could be discussed, that perhaps other things that have happened since have attenuated that, like voluntary contributions in secondary schools. But it's a long way from the way in which we organise our healthcare system. So is this now to be the decade in which we move to universalism in healthcare? I think at least the Programme for Government started the decade by reframing the debate about healthcare in Ireland, moving it a great deal on, for instance, from the point at which it was when one of our senior politicians referred to universal GP care in 10 years previously as a loony left idea. It's now a mainstream idea. So this government's move to universal GP care for the under sixes and restoring universal GP care for the 70s and overs is a very significant, very historic step towards universalism in this country, in my belief. Let's look at the case for universal GP care, because I think in some of the discussion that there has been in the columns of the newspapers and so on since the free GP care for the under sixes has been introduced, there has been a debate about whether this is a desirable place to go. So I think it's useful to look at some of the evidence. This is a study that was done looking north and south. It was surveying people about the effect of user fees on their usage of GP services. And it was found that in the Republic, nearly 19% of patients had had a medical problem where they had not gone to see a doctor in the preceding year because of the cost. And that was 4.4% of non-paying patients. So one has to assume there were other costs. Perhaps they felt, what's the point in going? I won't be able to pay for the drugs. I don't know. They didn't pursue that. But over a quarter of paying patients, of people without medical cards. And unsurprisingly, in that grouping, the poorest and the most unwell were those most affected. And this compared to under 2% of patients in Northern Ireland, on the same island, where there are no fees for GP care. Now, this finding is very much in accordance with the international evidence. There was a famous health insurance experiment in the US in the 1970s called the RAND experiment, which looked at the effects on usage of health service of people who did and didn't have insurance for services. And they found, interestingly, that user fees reduced the use of health services, both that were necessary and that might be deemed unnecessary. Because one of the things that people say, some people say, who oppose the removal of fees is, well, a whole lot of people are going to turn up who don't actually need the service. The difficulty is that patients aren't in a position to judge that. And if they don't come, they may very well need the service. And this was what was found. The effect, again, was most evident for low-income groups, unsurprisingly, and particularly interestingly for low-income children. And since then, other studies in other countries and systems have replicated this. So what are the pros and cons for GP fees? So there's evidence that they deter necessary care. And I think a key point to remember about this is it's not just the GP's care. We have a system like the UK where the GP is called the gatekeeper. You need a GP referral to go and see a specialist, particularly in the public system. And you probably need that specialist referral to actually get in for, say, elective care or for a test. If you don't go to see the GP, who knows what serious condition may not be diagnosed? And for the society as a whole and for the economy, your deferred consultation may lead to you presenting with a much more acute condition, which is much more costly to treat, may be disabling in the long run, and which leads to higher costs for you individually and for society. Universal free GP care, we have estimated in work in the SRI, could potentially improve health outcomes at quite low additional cost to society. And potentially, and this is something we haven't examined the cost-benefit of, and I'll come to this in a later slide, but potentially it might be the case, if we examine it, there might be no additional cost to society. So those are pros. What about the cons? Why not free GP care? And really, I think Ruth has explained this already, and I think this slide says it all, if you can see it there. This is a cartoon from Dublin Opinion in 1951. It shows the then Minister for Health, Dr Noel Browne, at the gates of the Irish Medical Association's castle. They say, Sir Noel, that they too have been rescuing mothers and children for quite a long time, and that while they admire your intention and your courage, they think you should be guided more by their advice. It was the opposition, as Ruth has said, of the medical profession and the opposition of, at the time, strangely, the Catholic Church, which saw free GP care for children, which was essentially at the heart of the mother and child scheme, as socialism. And of course, the Catholic Church has moved way beyond that since. So I don't suppose there's anybody in the castle now. What is the cost of free GP care? There are different ways in which you could estimate it, and of course, ultimately the cost comes down to bargaining, implicit or explicit, between the state and the medical profession. But by a methodology which we have used, which is where we basically use survey evidence to look at how many visits do people have to the general practitioner when they have to pay fees, how many additional visits, is there evidence that they actually use when they acquire a medical card, and by combining those and looking at the average fee, we can see the sort of income that GPs might argue they need to pay for free GP care. And it is approximately 2% of overall health and social care expenditure. And I'm using a percentage there rather than millions because, of course, that varies depending on which year you do the calculation. So what is a big and deterring payment for the individual is a very small payment for society collectively. And if you moved to free GP care, and why I could say that it's a low cost for society, most of the cost is simply a payment going from your pocket to the state, and you are going to pay for it in another way, through tax or through another form of collective payment. So society is only paying more for those additional visits. And why I say that we might find, if we sit down and we analyse it, if we can find the evidence that actually it's at no cost, is if those additional visits prevent people turning up in hospital with much more acute conditions or having disabling conditions that mean they end up in long-term care, potentially it could be the case that it's at no additional cost to society in the round. So, to financing healthcare. I've deliberately separated universal access from the issue of how we fund it, because I think that the acceptance of the goal of universality and the principle of social solidarity, access according to need, payment according to ability to pay, is a much more fundamental societal choice than how we finance it. And in a sense, I think that in a lot of our debate, because for laudable reasons the Programme for Government talks about universal health insurance, but in a lot of the debate subsequently, the issue of how we finance has got ahead of the issue of why we want to have universal health care. And I think we need to be clear about the goal before we are concerned about the financing. If we're clear about the goal, the principle of prepayment for health care and progressivity in financing flow from acceptance of the goal and of that principle of social solidarity. Let me talk a little bit about prepayment. We're all used to prepayment. We prepay to cover risk all the time. We insure our houses. We wouldn't dream of not insuring our houses. We even insure our travel. Some of us have private health insurance. And what do we do when we prepay? We create a collective fund so that we do not have to pay ourselves. We wouldn't be able to if our house was burnt down. And we also prepay by taxation for public goods like roads, schools, hospitals, and for public services. When an expert group appointed by the then Minister for Health, Mary Harney, reported in 2010, they advocated prepayment for healthcare, and they endorsed the social solidarity principle of payment according to means. So how might we prepay? Well, there are lots of ways of prepaying. You could prepay by having a purely tax-financed system like the NHS in the UK. You could have social insurance financing like in Germany, paid through your PRSI. You could have state-subsidised private health insurance financing like in the Netherlands. And most countries actually mix those methods to some degree. In fact, in Germany, long-term care is paid for through social insurance. Many other countries which actually have social insurance for healthcare still have a different tax-funded system for long-term care or payment out of pocket. Particular advantages to a social insurance approach are that it creates what they call an earmarked fund, so everybody puts in a contribution, you can see what's there, and we all know where it's going. And some people find that a good argument for that. The government published a white paper in April of last year, which began a consultation and research process, and which I think is ongoing. I think it's safe to say that since no two systems are the same, the Irish system is likely to be unique. Whatever system emerges from that consultation and research process, it's desirable that it will support universality and improved health outcomes, adequate resourcing, that it will find a way to ensure adequate resourcing, and that it will be transparent with clear system of eligibility, and of course that it will be cost effective. I'm going now to the case for universality in hospital care, and this may look like an odd way of doing the sequence in this talk, and the reason why I am is because I want to introduce some of those concepts of prepayment and so on before I talked about hospital care, because there is a paradox in how we organise our hospital care in Ireland. We have already accepted the principle of universality in hospital care in Ireland. Since 1979, everybody in Ireland has been eligible for free maintenance in hospitals, subject to the overnight and ED charges which came in subsequently. In 1991, everybody became eligible for consultant care without charge in Irish hospitals. We also accept prepayment by taxation for universality in the public system and by insurance, private health insurance, for private treatment. So we've accepted the two principles, but somehow we still have managed to evolve a system where there are charges and where there is two-tier access to public hospitals. And of course, we all know that the two-tier system is iniquitous, that it's very hard to defend faster access for the insured to public hospitals, and that this is a consequence of running two parallel systems. And the government did commit to ending the two-tier system of unequal access. What are the effects of this? For the individual, late diagnosis and treatment. I think everyone here, will recall the sad, tragic case of the late Susie Long, who was too principled in her case. She could have afforded it to go private and ended up with catastrophic late diagnosis and treatment. Society bears the cost of poor health outcomes more than we've ever quantified. We also collectively carry this psychological burden of insecurity about access to care and need. The economy carries the costs of greater ill health, and I think also carries the costs of the administrative complexity of these duplicating systems. I don't have the time, and I won't pretend I have all the answers, to how you reform the two-tier system. But I would say there are these prerequisites, that you have to have a reform backed by adequate resourcing and with equitable access. And I think we have models already. The National Treatment Purchase Fund model of purchase of private care for people on public waiting lists, it seems to me, could be expanded. And in a move to the sort of split between the purchaser and the provider of care, which is a feature of modern healthcare systems, it might be that we could have a similar application of this model in the public system. I'm moving towards the end now, Chair. These questions of universality of access and of how we finance it are happening or being discussed rather, against a very challenging backdrop, which is the challenge of ageing. And it seems to me, and there isn't time definitely to go there also in this presentation, that we need a secure prepaid system for our social care, whether in the community or in a residential setting, and with clear criteria for eligibility, which we do not have now. And I think the other big challenge is the challenge of, if you like, an agreed societal commitment to adequately resourcing our health and social care system. Because we need to be able to plan for the development of the service, and we need to be able to use evidence, and we should be able to use evidence to anticipate the demands and not to have perennial budgetary crises in health. So in conclusion, it would seem to me that there is a strong case to be made by proponents of healthcare reform that a universal healthcare system, like universal education, is an investment, not an overhead. It enhances human potential, which economists call human capital. I think it's a prerequisite for a well-functioning society and economy. And bringing together all those lenses of the individual, society and the economy, I think they can all be reconciled by saying that a system that provides security of care in need is in the interests of all three, the individual, society and the economy. And this was seen, or rather the human capital argument was seen by the person who introduced the first social insurance universal system in the Prussian dominated German Empire in 1883, Count Otto von Bismarck. He saw a clear argument for investment in healthcare to have military and economic efficiency. That's the human capital argument seen through the 19th century lens. But to show that universality is indeed universal, I'll give you a more later lens. I'll end there. Thank you.